Okay, well, welcome everyone on this lovely sunny day. We have a presentation from Stacey Evans-Charles on tissue viability later in the agenda, so welcome to Stacey. We've had no public questions, so there's nothing to answer in terms of questions. So I think if we may, we'll get on with the meeting. Any apologies, Julie?
No, it's a full house.
Excellent. Declarations of any other business? No. Declarations of interest in the register or the agenda? No. Minutes of the meeting then held on the 9th of February, item 5.1. Any corrections, please? No. Matters arising. As far as I can see, they're all either actioned or not yet due, unless somebody wants to raise anything. Okay. In which case, we move swiftly on to Stacey. So welcome, Stacey. Are you there?
Hi, yes, I am here. Thank you.
Thanks, Stacey. I think now you've got a patient story on tissue viability, so I think over to you.
Thank you. So I'm Stacey Evans-Charles. I'm the tissue viability lead for BHFT. I just wanted to share with you a patient scenario because I think sometimes it's good to share success stories about patients from a multidisciplinary point of view, and just to raise awareness of how we support patients in particular nursing homes, and how we can have a positive influence on the patient and work as part of a multidisciplinary team. So I'm going to speak to you and share this particular patient. Can you see this?
That's fine, Stacey.
This yeah. So this is about, of course, promoting the role of the tissue viability service in nursing homes, where historically we wouldn't necessarily, for example, undertake leg ulcer assessments in nursing homes with a view to providing compression therapy. And we'll talk about leg ulcers and compression therapy in nursing homes as we go further on. So the scenario is a patient who is 93 years old, female, with a past medical history of heart issues. She's also got Alzheimer's disease. She's got blood pressure issues, again, adding to her heart problems. She's got irritable bowel syndrome and an actual diagnosis of heart failure. So she was admitted to hospital, and it was decided that she was unsafe to go back home. So she was discharged to a nursing home due to not managing at home and after lying on the floor for a very long time. She has a history of leg ulcers, which were not treated in hospital with compression hosiery. Now, the gold standard guidelines recommend compression hosiery, to manage leg ulcers in order to promote wound healing of these ulcers within 2 weeks. This lady did not have compression hosiery while she was in hospital. But the nursing home was, however, advised to undertake a Doppler and to provide her with compression therapy to heal her leg ulcers, which she had for 9 years. So the assessment involved, of course, taking a full history taking of the patient, including her medication and any past medical history about her, risk assessments such as her Waterloo score, which is used to tell us about her mobility, and other scores that could possibly have an effect on her pressure ulcers, on pressure areas, and her dietary, intake, and her risk of malnutrition with this MUST tool. So, in addition to that, we undertook an ABPI, which is an ankle brachial index that helps us to ascertain if the patient sits within a safe range of 0.8 to 1.3 as per national guidelines, to suggest that she is suitable and safe to have compression in conjunction with a full and holistic assessment. So one of the things that we noticed as part of her assessment was that she had these pitting leg edema, and that indicated that she had some sort of acute heart failure episode. And of course, we probed a bit more around her breathlessness and her heart failure, and the nurses in the nursing home, sort of supported in the conclusion that she had some acute heart failure episode. And in addition, she had edema below the knees. So we liaised with the heart failure nurses to ensure that her heart failure medication was optimized and that her heart failure would be stabilized. We also used the TIMES model. So this is talking about the tissue, whether it's inflamed or infected, whether it's macerated, the exudate levels, looking at her social issues. And we applied all of this to her holistic assessment. And we waited for feedback from the heart failure nurses. And they agreed that although, reduced compression would be suitable, she needed to be optimized. So she was seen by the heart failure nurses. They implemented a 1.5 liter restriction. She had daily weights to monitor how much fluid she was losing from the body in a safe manner, because what happened was they increased her furosemide from 40 milligrams to 80 milligrams a day. And of course, they'd be checking her bloods for her kidney and liver function just to make sure that she wasn't going into any renal failure. And of course, refer her to physiotherapy, because one of the things that needs promotion is mobility and exercise as part of her into holistic assessment. And within from the time we saw her on the 15th of the 10th, so roughly 5.5 weeks later, the wounds on her legs had completely healed. We liaised with the heart failure nurses again to see if she was suitable for compression, and they felt that she was not optimized enough because she still had some pitting edema and some breathlessness, and there was that risk of pushing the fluid up from her legs into her heart to induce pulmonary edema. So we did not apply reduced compression at that point in time. However, the family were actually overjoyed that her leg ulcers were healed. The patient was in her elements that the leg ulcers had also healed. And this is a photo of the patient's legs. Now you can still see that her legs are still quite swollen and edematous, but there are no leg ulcers. And so this case study just confirms how working from a multidisciplinary point of view ensures safe best practice, because we're putting the patient at the heart of patient care, but we're also working to ensure that she has best evidence-based care so that her interventions are, safe for her and doesn't cause her any harm. This case is quite unique because we often come across barriers to managing leg ulcers in the community, and in particular, nursing home staff, they would not have undertaken a lower limb assessment training. They would be unable to undertake ABPI assessments. And so from a safety perspective, they wouldn't be able to provide compression bandaging. And so one of the things that we often have to do in order to promote accountability and responsibility is to work with the reps that support us with equipment such as compression wraps, ready wraps, and hosiery for patients who reside in nursing homes, so that we ensure they still get compression, the right amount of compressions, but in a safe manner to help reduce their limb edema and to sort of help their leg ulcers. So this was just an example of how we work from a multidisciplinary point of view in the community, and how it can have a very positive effect on patients, their next of kin, and then, it forms a better working relationship with staff in the nursing homes to allow them to understand that the patients can have a good quality of life if we approach things from a multidisciplinary point of view and accept that there's an accountability and responsibility to ensure that we still provide best and safe practice for the patients. So I just wanted to share this with you to promote our service. So thank you for the opportunity.
Stacey, thank you very much. I have to say, a most interesting and very, very clear presentation. That's fantastic.
Thank you.
I know, and the work that's going on is clearly very beneficial to our patients. So thank you for that as well. I guess the two things, I'm sure my colleagues will have some questions, but just for me, two things came across to me. One was the multidisciplinary working between our staff, the heart team and your team. But the other was between us and the nursing homes, where the nursing homes may not have all the skills that we have. Is there more you think we can do to promote joined up working with the nursing homes? Are there ways to reduce that risk of misunderstanding or people in nursing homes doing more than they should do? Do you have any recommendations, any thoughts on that?
Well, we have some liaison. So in the West, we have Wendy Hunter, who works with the nursing homes.
Right.
And what we've been trying to do is to get nursing home staff to attend the 2-day training that we provide for the trust, because we have practice nurses who attend them. And I think because they're independent of the NHS and they're often run perhaps by Bupa or let's say the Grange and others, Care UK, it's often difficult to engage and encourage them because of the cost implications that the trust charges these particular nursing homes. And so I think what I've certainly done is we've got people who are sort of involved and who have become sort of reps for their particular nursing home. And we encourage them to attend our study days. But when it comes to the actual legals and management, they're not very keen to, because it's not free as the other courses would be.
Yeah.
So it's just unfortunate.
Understood. Now, I've got some questions. Chris Fisher and then David Buckle.
Yeah. Hi, Dave.
Hi, Stacey. It's Chris.
Hi.
I just want to say that's fantastic. I have personal experience of this in my family, where my grandmother, for the last 20 years of her life, had horrendous leg ulcers, and in the end, it was a thing that I would say dragged her down. She became completely immobile, and there was absolutely nothing like the service that you are offering, or you offer to this particular patient. The various groups, didn't or wouldn't talk to each other. She couldn't have compression, then she could, then she couldn't, and all that sort of stuff. So I think of all the things that can weigh down the elderly and make life miserable and difficult to live, I think this is one of the most important. So, well done.
Absolutely.
I think that was fantastic.
Thank you very much.
David.
Great to hear what you've got to say, Stacey. Thank you very much. I think the term tissue viability is one that many people don't really understand. So you translate that for us. And I would also say, as a clinician, the concept of swollen legs, many people think doesn't sound that exciting from a medical perspective, but from a patient perspective, as Chris has just said, it can be very miserable for ages, for weeks, years and months. Leg ulceration. I had a patient who I had to clean the floor after they'd been in the room because their legs wet just from being in my consulting room. So it can be very severe. Maybe for most people it's just a misery. So it's really good to hear what you've got to offer. My question is very simple. As a GP who retired 5 years ago, one of the things that used to make my heart sink was trying to get help for these people. It really was difficult. And everybody in the NHS would say it's some other organisations' responsibilities. So from a patient perspective, do you think access is better than that now? Are patients getting through to specialist nurses like yourself? I just worry that however good a job BHFT does, that there's a lot more out there who could benefit from our care. There
is a lot to be had still, because there's still a lot of misconceptions about tissue viability as a specialism. The other thing is there's not the access to services that the patient that perhaps you're talking about needs. Because if they're having that much lymphoria, they may have an element of lymphedema.
Yeah, of course.
Absolutely. And so there's this disparity between chronic leg swelling, which eventually can lead to lymphedema, and it's actually the same thing. It just depends on chronicity. and the amount of time, in addition to which we also need to differentiate the type of lymphedema, whether it's primary or secondary, and the presentation of the patient. So there is an issue with access to services, which we are not commissioned at this point in time to maximize our intervention for these cohorts of patients. And we're finding more and more patients with what we would call lymphedema, and having to manage them when they're past the stage of us being able to provide that service in the community, primarily because they've been managing on their own quite well, and then they become septic and have cellulitis, which they're much more prone to, and so they then become debilitated and dependent on our services. We may have had interactions with them earlier on and not picked up that their legs were actually swollen, and perhaps they should have gone into compression after a limb assessment, because we've become quite a task-orientated service for various reasons. But there is still a need to manage them more effectively in the community, because there needs to be a better understanding of how larger limbs occur and the elements that sort of join into that particular issue. So there's still a lot to be had.
Well, thank you. It's really good to hear about what we can offer, and I think it's a question for me to go away and consider in the quality committee about whether the size of that service is sufficient.
Oh, it needs to be expanded. I mean, we're having to get the GPs often to refer to St. George's lymphedema services, or Oxford lymphedema services. And of course, we're only commissioned to provide compression to the knee, below the knee, because it's lower limb. We don't do above the limb, and often these patients will have swelling in the stomach. So that is more of a specialist area.
Yeah, well, I apologise to the executives for stirring that one, but I just remember I remember it as being such a problem for me as a GP. Thank you very much.
David, thank you. We got 3 more questions, so we must press on. Julian, did you want to come in next?
Yeah, thanks, Stacey. A really clear presentation, but also I suppose what struck me was the passion for the work that came through, not just the clarity of the work. And then I was just a very quick, if you could, it's almost like presented as if these things just happen. Is there something, given the nature of the work we do as an organisation, where we see many patients, is there a preventative element to our work as a community mental health trust that could actually intervene a little bit earlier, rather than you've been faced with sort of that very, very complicated things? What is that? What does that look like? What does this preventative work, what shape does it take?
I would leave that for the DN team leads to say, because they're the ones that come across these patients when they go in to give insulin, when they go in to provide care that has nothing to do with the lower limb, but the patient clearly has lower limb issues, but they're not there to do that. And that's your preventative measure before the patient becomes completely debilitated and dependent on us. So that's a conversation that needs to be had with community services. I can't answer for them.
It's a really good answer, and it's a bit of an adjunct and a bit of a balancing point for David in his quality committee, isn't it? Which is, do you put more resources, or do you try and do a bit of prevention as well in terms of this early intervention or whatever? So sounds like we're going to have a good debate in our quality committee. Thanks, Stacey, as ever. Really good stuff.
Thank you.
David Townsend.
Thanks for the presentation, Stacey. Really good, really useful. You mentioned about collaborative working, and we're doing some work at the moment with services on looking at their referrals and looking at their demand, looking at their capacity. And one thing I'd be interested to hear from you is, what's your experience of those internal referrals? Would you generally say that they're harder than an external referral, or are they dealt with quicker because you're internal? So what would your experience be? Is it a good experience?
So in terms of triage, we have a triage protocol. So there are patients that take priority over some other patients. However, we do make contact within 48 hours to all referrers. As I said, we're having a lot more patients with lymphedema and lymphoria. We have to liaise often with the GP in terms of prescribing antibiotics for longer periods. because as we're aware from British Lymphology Society, these patients need to possibly be put on prophylactic antibiotics, may need antibiotics for a longer period of time, and sometimes GPs prescribe as they would for a normal attack of cellulitis. So there's that multidisciplinary approach to things. However, it's based on triage, it's based on presentation of the patients and what the feedback I'm getting, whether the patient is end of life. So it depends on, it's multifactorial in terms of how we, sort of how soon we go out and see these patients. But most often than not, we see these patients within 5 days, no later than. One of the difficulties that we're experiencing is providing an ABPI, and all the guidelines recommend that we don't necessarily have to do an ABPI on patients with lymphoria and lymphedema. It's still guidelines that we should do a full limb assessment, but in order to be safe and to know that we're doing, a good job, we would rather do an undertaking of an ABPI. Where that is difficult, Julian has quite, kindly agreed with us for a toe Doppler, and so we now have access to a toe Doppler. I have liaised with the company to undertake training for TVNs and also for the wound care nurses in East and West, so that we can, sort of reach out to these patients much more sooner and provide them with the right equipment for their management, and work with the GPs to get them referred to the lymphedema services.
Thank you, Stacey.
Thank you, Stacey. Last question, be pleased to know. Aileen.
Yeah, thanks for the presentation. Like Chris, I've got a father that's got very similar situation. You mentioned physiotherapy. I was just briefly interested to know where that fitted in.
Oh, physiotherapy for the limb movements, because the patient may be immobile, but we need to make sure that the patient is still mobile, because we need to get that circulation, even if it's just dorsal flexors. It's about promoting their independence and their best quality of life. That patient may now, and this lady was able to move from bed to chair, but she wanted to move around her room, and she wanted to go out and engage with other patients, to sit out in the day room to have lunch. So it's about how we promote their independence and their quality of life with the symptoms that they're presenting with, and while we're working with other services to ensure that they're safe and they're comfortable. So that's where the physiotherapy comes in.
Perfect. Thank you.
Thank you.
Stacey, I think time is against us, but can I just say a big thank you to you and your colleagues. It's really impressive what you're doing, and very helpful for us to understand, the detail of this. I think I've taken away 3 or 4 things. One is the commitment of you and your colleagues, which is fantastic. The second is this sort of joined up message, whether it's about prevention through to treatment, the NHS to the nursing homes, or indeed the different specialities within our own teams, making sure all these sort of join up in an appropriate way. And I think you've made the case very clearly. So thank you very much indeed for your time.
Thank you for having me. Thank you.
Very valuable, and good luck.
Thank you very much. Take care.
Thank you.
Bye-bye.
Well, that was a great presentation. Very impressive. We have to move on. Item 6.1 is the Quality Assurance Committee. David, can I hand over to you, please?
Thank you, Martin. We had a very useful and productive meeting of the QAC on the 2nd of March. I believe the QAC is functioning well, and I'm of the opinion that we're getting a high level of assurance with quality papers. Thank you. Therefore, today I have nothing that I wish to escalate to the board, but for your information, we did have a detailed presentation on physical health monitoring, which is a clinical issue that's been around for a long time for the whole of the NHS. We obviously had updates about COVID, and we reviewed our clinical audit and the quality accounts. So I think I can leave it at that.
Okay, any questions for David on the committee? We've now got 2 subordinate papers, the learning from deaths. Minu, did you want to speak to that, or?
I won't be saying much. It's just that it's a fairly standard and rather unremarkable report, because it's Q3. We have to remember this is the time before, between all the all the peaks and surges. So the next report will look different in terms of lapse in care and numbers, etc. But this one is a very reassuring report about the quality of care we're providing when we look at it from the lens of deaths of patients in our care.
Okay. And Martin, can I just assure you that the committee did look at all the papers B and C and were quite content.
Thank you very much. So just formally, we note that, and also the Guardian of Safe Working looks a very positive report, Minu. So unless anyone's got anything you wish to raise, it looks really good. Thank you for all the good work that goes on. Okay, Debbie, 6.2 Infection Prevention and Control Board Assurance Framework.
Yeah, thank you, Martin. Yeah, this paper's here for information, really. It's an updated version of what it's a substantial assurance document in relation to infection control and COVID. Following our last submission of this BAF to NHS England in January, we've received no feedback, but there was a revised version published in February. So I'm guessing they used all of the returns to revise the framework a little bit. We do review this really regularly, and we don't have any significant gaps without mitigation from my perspective at the moment. The biggest challenge is going to be the ensuring ongoing continual compliance, I think, really, especially as lockdown eases. NHSE have published a toolkit called Every Action Counts, which has been developed in conjunction with psychologists to help that issue, recognising it's a national challenge for people to be compliant all of the time. And we're just working through those resources now. There's nothing in there that we haven't got our own versions of, but we will be working through to see if we want to actually switch some of them to these resources. Most notable things since you last saw this document, we've updated the visitor guidance, and we will be encouraging all visitors to take up the twice weekly lateral flow testing kit availability now that it's nationally available and published on the website, how people can get those kits, as well as we'll let them know when they come in for visiting. And just because I need to just update you on fit testing as part of this assurance, we've got an ongoing programme to retest staff for UK masks. That's going really great. We've got no concerns about that at the moment. We're providing some more training sessions in May, because although we've got 70 fit testers, obviously there's turnover, and we want to ensure that we maintain a good level of fit testers in the organisation. And that's all I wanted to say, and happy to take any questions.
Thank you, Debbie. Any questions? No. Okay, that's fine with Debbie. Thank you very much. All looks very well managed. Thank you. 6.3, proposed changes to how the Care Quality Commission inspects. Back to you again, Debbie.
Yeah, I brought this paper here really just again for information, to highlight the changes proposed by the CQC with regard to their inspections. I mean, in short summary, the proposal is for more smaller targeted inspections with wider use of available intelligence, as they've been doing actually throughout the COVID period, and with a very much reduced pre-inspection documentation pack required from organisations, which I'm really pleased about, prior to any inspections. They're also proposing the ability to change core service line ratings without an on-site inspection, where they have significant intelligence, whether that be positive or not so good. And there will only be one single overall trust rating. So rather than the complicated aggregation up for each domain that they have historically done to ensure that we have a score for each of the 5 domains at trust level, we will just have one overall rating for the trust, and then the core service lines will still have their 5 domains rated as they do at the moment. And that's again all I really wanted to say about that as information.
Got some questions, Mark?
Yeah, Debbie, thanks ever so much for this paper. I was really encouraged when I read it, because it appeared to just have so much common sense coming through it, and it seemed to echo a lot of the comments that you and the rest of the executive team have made in the past. The question that I had was, at the end, it talked about how to respond to the consultation and a closing date there of the 23rd. Did we formally as a trust respond to that? Because there seemed to be so much good coming through from those ideas. I wondered, had we responded, say we endorse those, or
yes,
in any
yes,
way?
I responded to say yes, it's definitely the right direction of travel. I think that there's some work to do with their insight report to make it much more timely. Some of the information in the insight report at the moment is quite out of date. But in the main, absolutely, it's definitely the right direction of travel, and has worked over the COVID period, I think, pretty well.
Okay. Thanks, David. Julian, did you want to say something?
Yes, just to say that, I mean, whilst the direction of travel seems sensible, I think that a logical conclusion is that many services are never going to be inspected at Berkshire Healthcare, and that Debbie's quality concerns and those type of things will be key for us, because that's really the areas that are most likely to be inspected. So we could, you know, over the next 5 years, find the same services continually inspected because they're higher risk, higher profile, you know, or in less good shape, really. So that will certainly change the interaction the trust has with the CQC and also our services. So some services may never ever see the CQC, and others may actually see them quite often.
So the way that we address that a little bit is through our regular relationship meetings, and we allow and ensure that staff showcase some of the really good stuff, and staff like doing that to the CQC. So it gives them a real opportunity to share some of the good and innovative stuff as well, and also inviting them along to things as we do them. I think we need to get better at doing that, so that they have an opportunity to see things when we've got presentations and things going on. I invited them to the Civility event a couple of weeks ago, because I think that just all helps shape the information they have available to them about what's going on in the organisation, positive as well as where things flag as risks.
Yeah, I guess it's one of those things where we need to make sure, I mean, we have a good process of assurance in terms of the quality of the care, but we need to make sure that's really strong, such that we don't rely on CQC inspections, as it were. As Julian says, lots of services may not ever see a CQC inspector, but we need to be convinced as a board that nevertheless that there's nothing hidden there. So it just gives more emphasis to the very good way of measuring performance that we've already got in place, but we mustn't let that slack. I think the general direction of travel looks fine to me. The only thing, it's a trivial thing really, but just the aggregate assessment for the trust, having just sort of one judgment made, there's just a danger that things become a bit subjective, and I think we need to make sure that whatever judgment they make of these very simple statements about the trust as a whole is evidence, so that everyone can see why they've made the decision they've made, even if it's a good result. We still need to see the evidence, but I think the direction of travel is fine. Okay, Debbie, thank you very much indeed for that. I think we're done on that. Executive report, Julian, take it as read.
Yes, please.
Any questions for Julian? No? There's nothing I had. No questions? Oh, sorry, Chris.
Can I just ask a question about what sort of the attachment that's on the sort of COVID update? The elective recovery fund, as they call it, this extra £1 billion that's going into the system. At yesterday's Frimley governance group meeting, this, should we say, wasn't causing any great degree of excitement, because the view was that the recovery was at the level of cost rather than anything that enabled a sort of a contribution, and it was generally welcomed on the basis that therefore it encouraged good clinical decision making, because it was on the basis of what's right for the system, what's right for the patient, rather than what's right for the money. And that was a really, healthy conversation. I just wondered, and I don't know if it's you, Julian, or whether it's Alex, how, given that we're largely a block contract organisation, but and this whole thing is referenced by the elective activity as in 1920, do we have an opportunity to think about some of the areas where, you know, are we able to make some claims and put some schemes together? Because it looks like the next 5 or 6 months are, you know, are where that money is going to get spent.
Yeah, we've been discussing this in the systems, Chris, and we absolutely should be looking where our community services support elective recovery and link into those incentive funds. So that's a conversation ongoing. And we have services like podiatry that have, not podiatry, phlebotomy that have struggled to reach capacity and other elements. So we're definitely linking up on the plans.
Excellent, thank you.
Thank you. Whilst we're on the annexes, the anti-slavery statement, has anyone got any concerns about that? You're content?
Just very quickly, Martin,
Yeah.
just a quick question about auditing with respect to this modern day slavery statement. Do we have the availability to audit our suppliers? Because it just struck me as something that we might want to state within this document.
We don't have the resources to audit in depth our suppliers, so we would be seeking assurance from those suppliers in our supply chain.
Okay, which is why we're silent on it in the paper. Yeah. Okay, that's fine, Alex. Thanks.
And the only thing I was just going to observe in terms of the planning guidance paper, which may be for discussion at another time, was about workforce and about sharing. I'm trying to find the paragraph now on page 139. No, it's not. Anyway, somewhere there about workforce sharing, and it just struck me that it sounded a bit as though people have got lots of work, lots of nurses and things lying around not doing anything, and therefore if you move them around from one trust to another, it fills a gap. But that wasn't quite the image I had of our staffing position. And so unless these schemes are actually going to generate more staff or more efficient use of staff, I'm not sure I'm quite convinced that this is a solution to a problem. But maybe that's not for discussion now, maybe for another time. Perhaps wishful thinking, unless anyone's going to come in. Okay, I think on that, if I could just get my computer to respond. Thank you very much. On the executive report, staff survey results. Alex, this is going to be a
just to record in public through our public session, noting that the board has had the opportunity to informally discuss the embargoed results. I've summarised here in the paper. This is a great set of results for us, particularly in the context of the pandemic, and we are top scoring on staff engagement and also team working, and frankly that is fantastic contribution across the trust of our teams during the pandemic, and their view of working here and in their own teams to be scoring so highly within our peer group. Across the range of the themes, we're scoring above average in all but EDI. We've moved up a notch on EDI, doing well, but as we've seen in the presentation, still more to do there. So a strong set of results, but continuing to work on those differentials of experience. And as noted there, we have our people and EDI strategies that are very much focused on delivering improvements in those areas. So fantastic response rate, which makes the statistically significant improvements all the more valuable. And for 2 years running, we've had 60% response rates, well above the average response rate for our peer group as well. Hopefully the presentation is clear. Very happy to take any points of discussion or comments.
Any questions for Alex? I mean, we've seen the detail before in previous meetings, but any questions for Alex? Comments? Julian?
Yeah, Chair. Along with the data, there is 3 text comments as part of the survey, and there were several thousand, and I've read them all now. And there's a couple of things that I think just worth drawing out. So comments that attracted at least similar, hundreds of people saying the same thing. On the positives was during this period, the camaraderie. Actually, people use that word. It's not me summarising. It's quite interesting how often that came up. The desire to homework was massive, and communications. And it wasn't just the senior management communications, your staff briefing. There was a sense that managers generally had also followed suit and had communicated much more than previously, and they'd really valued that. On the negatives, the things that came up was PPE and the confusion around that in the early days. So a number of people realised the redeployment experience. So there was positives in the positives bit, but there was a few of those people saying, this was a fantastic opportunity. But a number of people said how stressful either the redeployment was or waiting for a redeployment that never actually occurred in the process. So it was a mixture of either people not being happy with the placement because they're fish out of water, or actually the process behind the redeployment was difficult for people. And then there was a much smaller group of people who were saying home working wasn't for them because their home circumstances were inadequate, or they were lonely and sort of missing sort of contact. But they were probably about a tenth of the comments around the positive bits of home working. I'd say, because we haven't drawn those out previously, I just thought that was worth at least drawing people's attention, because those comments are often quite rich, and particularly where you can pick out patterns, it's just helpful to see, really.
Thank you very much. I have to say, I just need to repeat in public how proud I am of the Trust for these results. It's been a fantastic journey the Trust has been on. And the thing that really gives me reassurance is not just the very good results, but that we recognise from the data that there are some areas where we need to do more. And as a trust, we're a learning organisation, so we use this data, we learn from it, and then we take action to improve things. So that positive learning culture, I think, is really important to me as well. But I think it's been a great result. So thank you to our executive colleagues for what they've done. If there are no other points on that, can I move on to?
So Martin, just one point. Obviously, on the areas where we did less well, say for example, in relation to workforce rates and quality standard, things like that. What I kind of noticed is that there's still quite a way to go, but in some areas we have made progress. So it just shows that you can make a difference. So, for example, year on year, we've improved that kind of perception of percentages believing that the trust provides equal opportunities, and a reduction in those people experiencing discrimination from their managers. But we've seen an increase in harassment and bullying both from the public and other members of staff. So again, it strikes me that we can make a difference, and I think we've got a couple of areas, particularly around that harassment, that bullying from colleagues, but also from patients, where we've got an inconsistent approach at the moment. Suggests that there is more to do, but when we put our back behind it, we can make a difference. It's not just something that's out there.
No, I agree, and that's what I'm trying to get across. That we look at the data, we learn from what it tells us, and then we put in place plans and actions to make it better. And so I'm with you absolutely. So a great result. Thank you for that, Alex. Finance.
So finance. This is I'm going to focus on the summary page, but very happy to take questions on the main report as well. And the summary page is indicating where I think we're going to land, and I'm going to see the year-end results today from the team. They're not saying we're too different from what's here. So in March, there's been quite a lot of movement and change, as you can see, in terms of that build up from month 11. Some very big adjustments coming through, particularly around the employees' pension. That happened last year. We have achieved additional funding for COVID from the Bob ICS. So for our COVID cost pressure of £2 million from the system reserve, which is good news. We've also negotiated some support funding from NHS England for our Tier 4 new community model. That's the 750,000 in the middle of the first section. And we are seeing a general underspend or slower recruitment than originally forecast back in October to our underlying cost base in pay. That all added together is bringing us to what is like to be around a break-even, give or take, on our reportable surplus deficit position. And when you strip out allowable systems for the control total, materially the impairment of 1.3 million. For our control total in the system, we've done better than break even by a further 1.8 million. Because of the improved I&E positions and additional cash that we weren't expecting, frankly, for example, the annual leave accrual funding has been cash backed. We've had to take in additional balances this year which need to be deferred. There is a very, very strong cash position above our original forecast of 39 million coming through. That's great news. The ironing position is great news, and considering the volatility we've had from various waves of COVID, I think we should be pleased with that outcome, that we go into the next year in a pretty strong position, frankly, and stronger than we might have expected.
Thank you very much, Alex. Any questions for Alex? I've just got one, Alex, which in the staffing page on 179.
Yeah.
There's a very big dip. I think it's is it nursing? I can't actually read it on my screen. Nursing staffing, the big dip in sort of April time. The plan, it shows a big dip in the plan, the green. I just want, just for information, can you just explain that?
Sorry, which page are we on?
Page 179.
179.
With the detailed staffing charts, and the top right hand one, the green plan line shows a big drop in the middle of the.
So the original plan line pre-April would have included a vacancy factor. We moved to a forecast view of our cost base in April.
Okay.
So based on staffing posts and a projected run rate rather than a historic vacancy factor. Okay,
thanks for that, Chris.
Just a question, really, and as we sort of exit what looks like an excellent outturn for this year and into next, at yesterday's governance friendly governance session, Rob Morgan outlined the basis for funding going into next year, and that the first 6 months in effect are based on the Q3 2021 actual position. And he said that within that, the overall system was okay, but within that, there would be winners and losers. I don't know if you've yet had the opportunity to look at it, Alex, but do you consider that we're likely to be a winner or a loser, or are we sort of somewhere in the middle?
I think we're, for where our numbers are in Bob, so within Frimley it's just the acute and
Sure.
the CCG. With our numbers in Bob look okay. So we've got our nominal plan set at £1 million deficit for the half year, and a rollover of COVID and deficit funding support into that position. So you can look at our run rate here against that view, and my sense is we should be okay, but obviously we need to have the conversations within the system, because there'll be other players in that system that will have a different view of their nominal allocation, and there will be discussions. But I'm not going to say we're content, but we're not overly worried at this stage.
Thank you. Any other questions for Alex? I guess the big thing, Alex, is going to be being clear about what happens post-COVID, isn't it, and unwinding everything.
Yeah.
That's going to be the difficult bit. Okay, can we move on then to the performance report, H1A, it's on page 186. Over to you, Alex.
So this performance report is a bit of context to the vision metrics as well, where we've seen a deterioration in performance in some of our key driver metrics around safety, in particular falls, self-harm, assaults. And we can also see in the 1920 benchmarking data on assaults, we've got a continuation of a problem which isn't just about COVID. And I think we just need to set that context. COVID will have exacerbated it in terms of focus and capacity, but we have a trend here that we need to continue to address through our improvement activities. And those are the key things I'd highlight, as well as the out of area placements. We had seen a significant spike up from December to January and into February, but we are now back very stable actually around our out of area placements into March and April, which is good news. And those are the key things I'd highlight. So happy to take questions.
Any questions for Alex on performance? Alex, oh, sorry, Julian.
Yeah, just to say, I think David and Debbie might know a little bit more. Just on my visits to prospects and places, I think we've had quite a few changes in sort of ward management, so in the last year or so, and some have probably been able to stick with the quality improvement initiative more than others. So I've seen a ward where it's still working very well and they're getting good results. But again, I suspect, Alex, although it's you're quite right, it's not down to COVID directly. I suspect there are some changes that have happened because of the pandemic that we now need in terms of our recovery to get back onto in terms of standard ways of working, using QI again to drive some of those improvements, which I suspect has in some areas has not survived as well as in others. A bit of inconsistency. So I think there's something, I think your point is well made. Hopefully, as part of the recovery process, get that back up and running. And know as an exec, we're doing exactly the same as well with our senior leadership team about, really pushing back hard now on quality improvement. Well, we've got the headspace to do so.
Thanks, Julian. I'm just going to ask a couple of points, if I may. One was about self-harm incidents, and I think Bluebell Ward sort of comes out a bit, but it's also got very high occupancy. I guess that's linked, is it, to the occupancy and the self-harm? Can anyone help me?
It's linked to a degree, Martin, but what I would also say is we've got quite higher than we've had in the last year, really, numbers of patients that are more likely to self-harm at the moment, which is also compounding the challenge. And whenever you have a number of those patients in together, we see a bit of a spike because people are feeding off each other a little bit as well. So there's some really proactive work going on at the moment to try and discharge safely some of those patients.
Okay. And the statutory fire training we're still sort of struggling a little bit, aren't we, to get where we need to be on that? I think there's somewhere about using more online training as a way of doing that. I don't know, David, is it? Can you answer that, David?
Yeah, I think we can return to some of the face-to-face. We've got online training developed and that's been available. I think most of the focus that I have is on the wards. Right. So I keep an eye on that to make sure that that's clear. I haven't looked at the overall figures for the other services for a while. I suspect it's just been the period that we've been through has meant that we've got behind a bit in some areas. But I'm happy to go and look into that in more detail.
Okay. Thanks so much.
Just to say, so it might be helpful just to share our approach in the executive during the sort of COVID period. When we've looked at fire, David's prioritised at our request the inpatient units and the wards where obviously there's higher risk. That's not saying the figure's not terrible everywhere else, but that's where we've prioritised the training activity for very obvious kind of reasons. But I think we'll be able to get it back on track. But I do think it's useful to have that context about where the attention has been to try and maintain that when obviously we've been under quite a lot of pressure. But we should look now to return that back to the usual standard over the coming months across the board.
Thank you for that, Julian. Any other questions? No. In which case, Alex, can we move on to 8.2 board vision metrics, please?
Yeah, to note the key changes are refreshed using the 1920 benchmarking data. And as I said just now, the ranking deteriorations in the assaults benchmarks, but a significant improvement is the use of restraint. And again, that use of restraint change has been backed by quality improvement methodology. So we show that it pays off and delivers using that approach. Aside from that, we're fairly static on the metrics because of the pandemic and because they're annual ratings. And as I said, in the matters arising, we'll be reviewing the vision metrics once we've finalised our True North refresh.
Very good. Any comments? I do like just seeing these top level things. It just keeps us sort of honest, as it were, in terms of where we sit in the bigger picture. And in the refresh, I think it'd be useful if everyone can have a chance to to decide or put their full pennyworth in about whether they're the right parameters we're doing. So we're learning as we go forwards. Okay. We've discussed the detail. For some reason, my computer's going very slow this morning. Naomi, FIP committee meeting of the 25th of March. Anything you wish to bring forward?
Yeah, Thank you, Martin. Really very little. Debbie and Alex have hit the high spots in the conversation that we've just had across the finances and our performance recording and management. You know, it's always nice to get to the end of the year and be in a comfortable financial position. And I think notably, you know, the moving parts that were evident in the last month of the financial year are, you know, perhaps give an illustration of, you know, what the volatility I think that we've had to manage over the last 12-month period. And clearly hats off to the team for being able to do that in the way that they have. Clearly we've benefited from deficit support funding and COVID funding throughout the period, and we'll enjoy that for the next 6 months period as well. But I think when I look at it through the lens of what has the team done to ensure that we have been able to keep stable financially through the period, you know, that's worthy of note, given that there has been such volatility and movement of staff and so on. I think just touching on capital expenditure to year end, we will be underspent, but perhaps no big surprise there, given some of the practical constraints that will naturally have come with the COVID environment, in particular as it relates to our estate. And going forward, the priorities now for us as a committee are going to be looking at the future, at the forecast, and how that's going to emerge. I think clearly initially on the next 6-month period, because that's when, you know, we'll still have COVID support. But I know Alex and his team will at the same time be looking beyond that. And I think as a committee, the area that we'll be, you know, keenly interested in, there'll be many areas that we're keenly interested in, but in particular, I think trying to deeply understand the value, and I stress the word value rather than kind of cost or cost saving, but the value that we think can be derived from new ways of working. Get deeply a thorough understanding of that and the value that it drives internally and indeed most importantly for our patients. We will naturally work through to a steady state in accordance with our recovery plan. And I think the other area of interest for us is clearly going to be how we benefit and draw down on our cash pile. That's, you know, we are in a healthy position. It's a little bit unexpected. Some of that is accruals. So, you know, it's funds that are already dedicated for expenditure in this new financial year. But I think in particular, it's going to be interesting to see how much flexibility we're going to be able to draw down on that through a CapEx and RevEx lens. So with that, I will just pause. Any questions?
Any questions for Naomi? No? Thank you very much. In which case, we'll move on to item 9. Is Catherine there?
I am.
Thank you. Catherine, Recovery Programme Highlight Report.
Thank you.
It's an important report and particularly important to our governors. I know you want to understand where we are.
Yeah, thank you very much. I'll take the report as read. Just a couple of things to highlight. The programme is now rated green rather than amber, in recognition that all services are now operational in one form or another, which is a fantastic achievement, and a huge thank you to all of the staff that have worked so hard. Since this report was shared with the Trust Board, we've had the operational planning guidance, which includes reference to recovery for community mental health services. We've also had some separate planning guidance around recovery of community health services, and they've both tended to focus on prioritising what we know as the urgent community response, of the 2-hour response that we have in the West as part of the Ageing Well programme, which will now be expected to continue in the East. And the conversations are very current with the Frimley Commissioners about continuing that service. Discharge to Assess is written large in recovery, and the enhanced health and care homes and anticipatory care planning, all of which we knew were on the landscape. So it's great that they've been highlighted. The only other thing probably to highlight is this reference to our people recovery plan, which the exec have now had a chance to consider and look at. So they're probably the highlights, and I'm very happy to take any questions or comments.
I've just got a detailed one to start off, Catherine, which is just for clarification. Top of page 231, it says BHFT has a dedicated reducing health inequalities, I think there's a word missing there, due to the impact of COVID, reports quarterly to the Recovery Programme Board. Could you just say just a little bit more about what that is?
Yeah, of course. So we actually now have two reducing health inequalities strategy stroke plans. One is what I call the eight action plan, which is the 8 actions that we were required to put in place as from following the phase 3 guidance, which is get the title right, the reducing the health inequalities impact of COVID, which we looked at not the last trust board, but the trust board before, which includes the actions such as making sure we're vaccinating those at risk, making sure that we're working with our partners, making sure that staff wellbeing is covered off. So we have what I call the 8-point action plan, which is actually also listed in the operational planning guidance. So we're well placed to deliver on that. Excuse me. And then separately, we've decided and developed a reducing health inequalities action plan, which at the moment is focusing on learning disabilities, physical health for people with serious mental illnesses, cardiovascular disease and respiratory. So you've got two reducing health inequalities plans in place. One's very specific to the impact of COVID, and the second one is much wider, not necessarily related to COVID, but those outcomes that are within our gift to make a difference to, both of which you looked at in the discursive going forward, and I think we've agreed will be on the June discursive coming back in a couple of months.
Okay, any questions for Catherine? Chris.
Catherine, hi. On page 227 on your sort of header sheet, in summary, you say resource impacts, yes, but currently unquantified. And it's probably just me, but I couldn't get over that as I was reading the next few pages, because it made me just wonder, does that mean that our plan is out of whack with either the money that we've got to deliver it or the physical resources that we've got to deliver it? So I just wonder where you are in the, should we say, effort towards producing a quantification of the resource impact that's required, and whether we indeed do have it.
Really good question. We've developed what we call a demand and capacity tool within the trust, which takes a look at the impact that COVID had on services, but also acknowledges some services had waiting lists pre-COVID. So there are two drivers there. But the heart of the answer to your question is the workforce that will be needed to be able to clear those backlogs, whether it's COVID or pre-COVID. So that work's very current. Each of the services have to, in a sense, provide an understanding of what it would take to be able to clear that backlog, taking into account the different types of contacts that we now have. So there will be some that are remote, which means you can, in a sense, fit more contacts into the day than previously. So we have the tool, but we don't have the answer yet for all of the services. It's going to be different for the different services. So there are some services we know, we've talked a bit about podiatry. We know that because of the infection control compliance that we need to put in place, it's going to be harder for that service to get back online, because they just literally can't see the same number of people in the day that they used to. Whereas other services have actually been able to fast track remote consultations and been able to make inroads into their waiting list. So there won't be one answer for all, but the tool is in place and we're currently populating it.
I mean, the reason I ask is, and it's not, whilst this particular example is not necessarily relevant to us, it's a really good thing to be thinking through. When we were having the conversation yesterday in the Frimley governance meeting, Frimley Hospital themselves were very concerned that during this period of, if you like, where the money is available for them to catch up on elective backlogs and all of those things, the very, very people inside their organisation that have been most greatly affected by the demands of COVID are the very people that are needed to help them clear their elective backlog, i.e. the anesthesiologists, and it sort of came to, and they said, you know, that we've sort of broadly come to the conclusion that the two are, I won't say you know, totally incompatible, but going into a period when staff are going to need to have some degree of respite from everything that they've been passed through, it's exactly the time that the pressure appears to be being applied through the subtle lever of money, or not so subtle lever, in order to, you know, make inroads into backlogs. And that sort of feels like, you know, it's likely to affect us in, but, you know, obviously not in anesthesiologists, but in other ways. So I just, you know, wondered how you'd thought all that through.
I think, I mean, the challenging area for us will be delivering the 2-hour rapid community response at the same time as delivering the MSK services, at the same time as continuing the hospital discharge services. That pulls on the same pool of staff. So that will be our equivalent area of challenge. So I don't have the answer as to how we're going to bottom that off, but I know that that will be our area of challenge for that one pool of staff delivering all of those services at the same point in time. So no easy answers, I'm afraid, Chris, but I do know where the challenges are.
Okay, anything else for Catherine? Catherine, you present quite a positive picture in terms of recovery, and thank you for all the efforts you and your colleagues are doing. I'm just wondering whether, not now, but whether there's any information the board could have which just indicates a bit more of a breakdown by the different types of service. You've got a sort of green overall, and your comments are sort of aggregated together as fairly generic comments, and they're very helpful. But there's sort of in the back of one's mind is always that question, what about this service or what about that service? And I think it'd be helpful if that could be available to the board to have a look at. Would that be all right? Yeah,
very happy to bring that to the next meeting.
Thank you very much. If there's nothing else, Councillor Governor's update, I'll give you a brief update. One is that elections are going on for several governors' positions, and we've worked hard to try and encourage as wide a range of people as we can. And my thanks go to Julie for a lot of effort she's put into this, to encourage people to take an interest, to explain about what the role is. I've used opportunities when I joined community meetings to, explain and encourage. So we'll see what happens, but I think we're beginning to make a bit of traction there. And the second thing, just to remind you that we've got a presentation from the chair of the Buckinghamshire, Oxfordshire and Berkshire West ICS, David Clayton Smith, at our joint governors meeting, NED's meeting, whatever it is next month, later this month, I can't remember, early May, I think it is, which will be very interesting to help us get up to date about the direction of travel in Bob. And we can sort of have an opportunity to ask lots of questions then. So that'd be a useful discussion with the governors as well. So we'll have a sort of a joint discussion. I've got nothing else to add at the moment. The Trust Seal report, Alex?
Just for noting, please, Chair. Thank you.
Okay, we have noted. Any other business? Date of the next meeting is the 11th of May 2021. And now we'll adopt our normal resolution to exclude press and public from the remainder of the meeting, as it be prejudicial to public interest. So thank you very much, everyone.